Dr. Diana Constanza Pulido holds a master's in public health and a master's in HIV/AIDS, with over 14 years of experience across clinical practice, policy research, and program evaluation globally. She has led health and nutrition integration in humanitarian settings, focusing on sexual and reproductive health, gender-based violence, maternal and child health, nutrition, and mental health. Formerly acting director of programs at Save the Children Colombia, she now serves as Global Humanitarian Technical Lead for the International Planned Parenthood Federation.
About cervical cancer, you can see here that cervical cancer is the fourth commonest cancer in women globally, with about 600,000 new cases by 2022 and 350 cases of deaths by 2022 as well. 9 in 10 cervical cancer deaths worldwide occur in low and middle income countries. As you can see in the heat maps, both of the trends are in the south, right, in the global south. 90% of those trends in 2020 were located or concentrated in low and middle income countries. What about the estimations or the projections of the new cases and also the death by 2050? You can go through the Global Cancer Observatory from the International Agency of Research on Cancer. It belongs to the IARC International Agency, and it is closely in collaboration with the World Health Organization, so you can go through it and just play and navigate throughout the dashboard. It will give you wonderful information and projections about different types of cancer, including cervical cancer, breast, prostate, lung, etc. So by 2050, we will have around or more or less 1 million of new cases if we do not do anything to tackle the situation. Also, we expect that 400,000 deaths will be in place by that time if we don't do anything to intervene from the public health perspective. So also you can find this type of graphics and pictures and these figures from the the Global Observatory of Cancer from IARC. So you can do some comparisons between the trends in regards. You have in the x-axis the categories from the World Bank in relation with some of the countries are in high income or low income, and you can see the trend of the new cases or the incidence per thousand of people, of women at risk. Unfortunately, the number here, the percentage didn't appear, but by 2050, high income countries only will increase their new cases in 7%. In comparison with the low income countries, plus 152 if we do not do anything around it. So by 2020, the World Health Organization launched the Cervical Cancer Elimination Initiative, and it is driven by this global strategy to accelerate the elimination of cervical cancer as a public health problem. It has 3 targets, special targets that should be accomplished or achieved by 2030. So 90% of the girls should be fully vaccinated by that time, 2030. And they should be between the years of 9 to 40 years. 70% of women should be screened with a high performance test by 35 years of age, and again by 45 years of age. And the final target is 90% of women that has been identified with cervical disease are receiving any treatment. So you have a precursors lesion, you should be treated. And if you have an invasive cancer, you should be managed. Are we on track to achieve this commitment that all the member states that belong to the World Health Organization are working or not in this issue? Are we working or not in this issue? So it's quite difficult to find out this data. However, the WHO organization has launched some of the impact sheets, some of this data, and also in some peer review surveys that have been done throughout the world, reviewing and searching what is happening with the programs and with the service, such as the health benefit packages service that has been done by the World Health Organization. So you can find if the package, the comprehensive package, is included in the health system or not in each of the countries that are committed to provide services, cancer services. So we have that 27% of the girls has been vaccinated so far. The last this number is taken from a fact sheet from 2023. So this is the last information that we have. Another information is that we have only, it was a review of the programs, this number. So we have that only 9 to 11% of women in ages between 30 to 49 years old in low middle income countries have been screened during their lifetime, against 83% of women in high income countries. So you can see the difference. Only 11% of the population. Can you imagine? I don't know. For instance, my country is a middle income country. I came from Colombia. Only 11% of the population has been screened so far. Against Belgium, which I'm living now, 83% of them have been screened at this moment. It's just numbers, trying to extrapolate it and put some examples here. The last one, unfortunately, is only in the global strategy. This number it came from 2020. So we do not have real data after 4 years of the launch of the strategy. So it says that about 30% of the low-income countries reported that they have a comprehensive care package, which includes pathology, surgery, chemotherapy, and radiology, and most of them, or some of them, they are using also palliative care. Again, 90% of the high-income countries, they have the whole package, against this 30% in low-income countries. But what happened in humanitarian settings? So a humanitarian settings is when a complex situation, for instance, a climate crisis related or a conflict or violent situation happens to the country and impacted the most important sectors, such as health is one of the first, shelter, also water, and finally protection. So what happened in humanitarian settings in regards of all type of cancer, but especially in cervical cancers? So approximately 84% of the 18 million people that have been forced in the last decade to flee their homes are hosted in low middle income countries, which are scenarios of complex and protracted humanitarian crisis. So again, I can put my country as an example. We have been facing the migration of from people from Venezuela. And in the border of Colombia, we are overwhelmed already. So we are fragile. We have fragile systems around the borders. Functional hospitals in Syria had available cancer treatment services, but only 46% of the patients with cancer in Syria had completed radiotherapy. So you can see that the trends are very different if you are in a humanitarian setting. Also, there are different factors such as demographic and epidemiological factors. Maybe we thought that because there is a humanitarian setting, it is not an epidemiological transition. So it is happening as well. So non-communicable diseases are also increasing in humanitarian settings. Why? Because they are not being treated, they have been being early diagnosed, and also we do not have the capacity to screen, to aware communities, etc. So if it's difficult in stable times, it will be even more difficult when you have a humanitarian emergency. Well, other factors that has been impacted, the possibility to treat and to diagnose early different type of cancer, including the cervical cancer, is also the awareness in humanitarian settings and the traditional approaches to provide humanitarian aid. More normally, we are providing primary health care to tackle communicable diseases, infections, also doing life-saving actions such as in SRH, for instance, in IPPF is working with the minimal initial service package, which means that we have a set of activities to implement in humanitarian settings or scenarios so you can life-save. Those are life-saving activities. We are not using, I don't know, it is quite expensive, and also the continuum of the care will be quite difficult to maintain in humanitarian settings due to the resources, but also the capacity to sustain it in time. But at the end, we have also this, it comes from the global strategy, so we have 3 main paths or 3 main pillars to tackle or to intervene this cancer, specific cancer. So the primary prevention, which aims to achieve the 90% that we saw at the beginning. So it's to improve the capacity of the health systems to provide vaccinations to girls and also to boys, and other different type of behavior risk actions and activities at community-based or also through public health programs. The secondary prevention is to use the screening with a high-performance test, which includes HPV DNA, cytologies, and also the visual inspection of the cervix with acid acetic. By the end, the tertiary prevention is to treat the invasive cancer at any age, including surgery, chemotherapy, radiotherapy, and palliative care.
Thank you, Dr. Diana, for sharing your experience with us. You gave a lot of information for us to think about our cervical cancer screening program, especially in low and lower middle income countries and in humanitarian settings. Now, you may ask questions from her.
Interesting presentation. And we can say that we have the vaccination in our schedule now, so I think we will reach there fairly soon in our country, so I'm really proud to say that. But that's in the school setting, so it's for the younger children. But women who haven't gotten in the past, so I'm in my 30s, so I haven't got my HPV during the school time because it's recently introduced. So it's, even though we provided MOH and Family Planning Association, it's freely available, people are reluctant to go get the vaccination. What are the strategies we can use to, I mean, there's awareness again like breast cancer for cervical cancer in Sri Lanka, but what are the strategies that we can use to bring them to get the vaccination? Even though there's awareness, they are not coming to get it. Maybe because of the stigma or related things. So do you have any idea how we can bring them to get the vaccination in our country?
Sure. So I think that the community mobilization is key for all this type of social behavior change activities that you can conduct to improve these behaviors, right? So for instance, if you have social organizations that are women-led, I think that could be a good opportunity to speak with them and from this feminist perspective, so also you can improve their capacity to be gatekeepers and to be part of the ecosystem, the health ecosystem, the public health ecosystem. So in some areas, you can use this type of connections within the communities, but also you can connect not just to develop awareness sessions inside of these groups and these peer-to-peer groups, but also maybe to have the capacity to connect them with the health clinics or the system, right? So you have, I don't know, a secretary of health that is at local level, and you can, maybe the person that is at the community level talking about or doing sessions, awareness session within this group of women, and you find out that this person would like to be vaccinated, but they don't have the capacity to go because they don't have maybe the funds, the resources to, because they have to pay or something. So maybe within these support groups, they can provide this type of like emergency funds to give their peers the possibility to go to the health centers to be vaccinated. So you can do some on-demand also activities, but within and throughout these organizations. it is even best when a peer tells you what to do, not the clinical or the staff, right? The provider, the healthcare provider is